Hello everyone, hi. Welcome to our webinar. Hope you can all hear me. So today we're going to be doing an hour on Cavernoma management, and particularly we're focusing on the CARE trial. So we've got an excellent group of speakers today, and I thought I would start really with going through just a very brief summary of Cavernoma management. I know we have a big range of people who attend these webinars, so we have patients and clinicians. So I'm just going to do a few slides going through the very basics of cavernomas and the context for the webinar. And then I'll just summarize the structure for the rest of the webinar. And right at the end, we're going to do a Q&A for 20 minutes. So if, as we're going along, you could put questions in the chat, in the comments, then we'll go through those at the end and hopefully get through the majority of them before the football starts later. So cavernomas are vascular malformations of the brain. It's quite important to understand that these are not tumours. So if this is your first diagnosis of a cavernoma and you come to clinic, they're not tumours, but they're bags of abnormal blood vessels. And in fact, we find that they're very common. So the prevalence is approximately, it's variable, but approximately 1 in 200 of the population, maybe 1 in 300. And we see them very commonly as an incidental finding on scans performed for other reasons. They occur in the brain or the spine. And the key thing about cavernomas is that they can bleed. Of those that are small and incidental, most of them actually don't bleed. So when you come to clinic and you see a clinician with a cavernoma, very often the advice is for surveillance, and sometimes they don't even need surveillance. So if there's no evidence of bleeding, they're incidental, and they don't cause any symptoms, they may not even need follow-up. But a subset of cavernomas can bleed, they can cause symptoms. When that happens, we recommend different treatment options, which we'll talk about. Just at the bottom of this slide here, you can see that this is a mulberry. This is the classically described appearance of a cavernoma. They look like a mulberry or a blackberry, and some of these pictures are what they look like when you remove them at surgery. And there are 3 main treatment strategies. So your cavernoma can either be monitored, so you can have serial imaging. If it's active, you don't want to treat the cavernoma up front because it's not causing significant symptoms or it's not bleeding. Often, the most common management for a cavernoma is to do surveillance. So that's either clinical surveillance or it's imaging surveillance with an MRI scan maybe once a year or once every few years. If, however, a cavernoma is causing symptoms and it's in an accessible part of the brain, they can be removed surgically, and that's often an excellent treatment for cavernomas because once the cavernoma is gone and removed with an operation, can't bleed again as long as the operation is safe. And then the last treatment option is stereotactic radiosurgery. One example of stereotactic radiosurgery is gamma knife radiosurgery. The benefit of this intervention is that it's non-invasive, so it doesn't require a brain operation. And it does not remove the cavernoma, but it reduces the risk of future bleeding. And I think one of the points that we'll be discussing in the talks is to what extent it reduces that risk of future bleeding, and then how do you weigh this treatment against the pros and cons of having an operation or surveillance. The indication for treatment is usually to prevent bleeding. And just to show you a couple of examples, cavernomas come in all different shapes and sizes, and that's why the treatments are very variable. This cavernoma, for example, is in the brainstem, and it's not symptomatic at this stage. So this cavernoma will be surveyed with clinical follow-up and radiological follow-up. This is also a cavernoma. So this patient presented with headaches and vomiting. She's bled from the cavernoma. It's causing a lot of pressure and swelling in the brain. So this patient has surgery, and that's clearly the right decision for this cavernoma. She has a small scar on the brain afterwards, but her symptoms resolve, and she has no future risk of having a bleed like that again. And then the last option we talked about, radiosurgery. This is the same cavernoma that was initially surveyed. Then there's a little bleed around it. The patient has double vision. And then the question is, We want to stop bleeding happening again, so the patient has radiosurgery, because in that location we feel that surgery is not feasible. So that's the very basic context of this webinar. Different cavernomas, different parts of the brain, different treatment options. What is the best treatment? And Professor Rustam Al-Shahi is going to talk to us about the CARE trial. Matt Raddatz is going to talk to us about his very broad experience, very wide experience of gamma knife radiosurgery for cavernomas. Ben Brady from the Cavernoma Alliance is going to go through his experience as a patient of treatment for his cavernoma. We also have Neil Kitchen, who's a very experienced cavernoma surgeon and radiosurgeon who works here at Queen Square. And then we're going to go through, after those talks, a live discussion and a Q&A for 20 minutes or more with your questions. So with that, I'd like to introduce the first speaker, who is Matt Raddatz, who's from Sheffield, probably has certainly the largest experience in the UK and one of the largest experiences worldwide with treating cavernomas with radiosurgery, and he's going to give us the benefit of his experience.
Thank you, Patrick. I think I skipped already one slide. Good evening to everybody. Welcome to this webinar. It's a great pleasure to give a talk on the experience of gamma knife radiosurgery for cavernous venous malformations here in Sheffield. We have been doing radiosurgery since 1985 and treating cavernoma since 1986. You can see the red curve, that is vascular abnormalities, and the majority of those are arteriovenous malformations, but part of those vascular abnormalities are cavernomas we have treated over the last nearly 4 decades. It's a multidisciplinary decision how to deal with cavernomas. You have multiple options, as Patrick already outlined. Observation or surveillance is probably one of the most common ones because those lesions are so frequently identified now on highly sophisticated MRI imaging we have nowadays available. Many of them are identified incidentally when scans are done for other reasons. Surgery, an excellent choice in a safe pair of hands, in particular when a lesion has hemorrhaged multiple times or is causing mass effects. And stereotactic radiosurgery. The choice of which one goes for at the end of the day will depend on the urgency of it, the clinical picture of the presentation, the expected success rate, i.e. complete resection, or is that feasible, and can that be achieved with an expected low risk? Or is that lesion placed in a very eloquent part of the brain where surgical resection might not be the most attractive way forward? So what are the unanswered questions? The question is it effective? Because with stereotactic radiosurgery, we do not resect this abnormality. So you will not have an MRI scan identifying afterwards that that lesion has been gone, has been totally removed. It is not being removed. It is being inactivated in the hope that one causes obliteration of these abnormal vascular channels causing hemorrhage. And there's no imaging modality which can show that one has been successful in achieving it. The question is it a real alternative to open surgery? And then, is it safe? There's conflicting evidence in the literature. In particular, the very early literature was quite scaremongering. And we couldn't replicate this kind of experience. And then the other question is it a real alternative to observation in non-operative cases? So the rationale of stereotactic radiosurgery is to reduce the bleeding risk, and that is by converting these abnormal vascular channels into scar tissue, called thromboobliteration. You can see here just a dose plan of a gamma knife treatment, which shows you the green lines where still some radiation is going, but that is not really damaging anymore, whilst the yellow line is a treatment line within which we achieve radiation-induced damage to those abnormal vessels. We had a very early experience that was published looking at our very small series on those days from 86 to 95. And the world literature at that stage was not very convincing. There were lots of negative reports, which we couldn't replicate. And so we carried on after our experience to treat CVMs. And doing so, we managed to accumulate a very large number of patients who underwent treatment here in Sheffield. So what are your treatment options? Obviously, a surgical resection and removal, like Patrick outlined earlier, is an option. This is particularly interesting in lesions which are not so eloquently placed. They are accessible. You have a surgical corridor. You can access them, which is non-eloquent. Lesions which have bled multiple times and where there is the patient suffering a progressive neurological impairment or increasing mass effect. Even in the best hands, those series published indicate that there's a significant complication rate. 14% of persistent deficits, nearly 2% of mortality, and 36% of permanent neurological impairment, even in large series in very experienced centers. And that's a concern because large centers with a good experience and good outcomes publish their series. But what happens in centers which are not as experienced and do not publish their series? We don't know what the results and outcomes in those centers are. So we looked at our experience of CVM radiosurgery, in particular looking at the deep eloquent cavernous venous malformations in the first instance treatment between 1995 and 2008. There were 118 lesions in 113 patients. 77 of those lesions had bled not more than once, and 41 fell in a high-risk group which had multiple bleeds before. The results of our study showed that radiosurgery was safe. We had only a mild morbidity, that means new neurological mild impairment in 7.3%. But we managed to reduce the annual rebleed risk of in the high-risk group from 30% to 2.4% after radiosurgery. So we concluded that radiosurgery stabilizes those lesions that have not bled more than once prior to treatment, and that the permanent morbidity, what we could show, was increasing due to repeated hemorrhages from the untreated lesions, rather than was introduced or induced by the side effects of the stereotactic radiosurgical management, which had radiation-induced side effects only in 7.3%, and new morbidity occurring because a patient bled despite having had stereotactic radiosurgery in the aftermath of it in 7.3%. So an overall 14% risk of suffering some morbidity. What was the outstanding question? Having shown that we can reduce that hemorrhage risk very materially, is not whether to treat inoperable CCMs with radiosurgery or not, but whether to treat them earlier. So not to wait until they have multiple hemorrhages. Why wait for a hemorrhage to occur, which we know causes materially increases the neurological impairment, from which patients then typically do not recover. So the principles of stereotactic radiosurgery are important because it's important that one can compare internationally published series. And for that, it is important that treatment modalities are similar or the same. Because if you do not do that and you do not standardize your treatment, then it is very difficult to compare and come to a proper conclusion. So we know that there's a significant difference between the hemispheric cavernous venous malformations and the deep-seated, eloquently placed cavernous venous malformations. So one mustn't put them into a study together because that will twist the outcome results. One should always follow a treatment protocol. So high conformity, not treating with CT-based treatment, but with highly sophisticated MRI imaging, to a prescribed and defined margin dose of 12 to 15 gray, one should stay within the hemosiderin staining and not to go outside, because that increases the risk of neurological sequelae. Often cavernomas present in scenarios where you have developmental venous anomalies as well, and they must not be included in the treatment plan because they are part of the normal vasculature, and if one damages those, one causes additional new deficits, which one can totally avoid by avoiding these venous anomalies. And to minimize the risks and the comorbidities of that treatment, to wait until in patients who had a hemorrhage, that hemorrhage has been mostly absorbed, so that one can actually focus onto the real cavernoma, which is often significantly smaller than the hemorrhage cavity, meaning that one would treat a much smaller overall volume than if one treats them too early whilst there is the hematoma still present. So they are all important factors. Now, the most important and the most interesting factor is obviously the bleed rate, because that is why we do this treatment. We want to reduce the recurrent hemorrhage risk and protect patients from the development of new neurological sequelae because of repeated hemorrhages. So what we could show is that pre-treatment, patients with multiple bleeds had a risk of bleeding in 32%. And that could be reduced within 2 years after stereotactic radiosurgery to just over 8%. And after 2 years, when the effect of the radiation treatment and the thromboobliteration is basically complete, down to 1.5%. So that is a very material reduction of recurrent hemorrhage risk. It is a little bit less obvious in the group who has had just one prior bleed. Patients in that group had a hemorrhage risk of just nearly 6% in the first 2 years following stereotactic radiosurgery, but beyond that, it reduced down to 1.6%. So again, if one looks at how many hemorrhages occur in that group over the follow-up years, that is 4 repeated hemorrhage in 250 person or patient years, which is a very small hemorrhage risk indeed after stereotactic radiosurgery. Now, interestingly, it doesn't go down to 0 in either of those groups. And if one wants to get it down to 0, then you do need to have a complete surgical resection. That there's no other way around this. Obviously, one wants not only to reduce that hemorrhage risk, one wants to achieve that by keeping the comorbidities as low as possible. It is not surprising that the deep eloquent cavernomas have a higher morbidity of 5.6% after stereotactic radiosurgery. These are related to post-treatment hemorrhages mainly, and there is a nearly 1% mortality. Due to radiation-induced side effects in the deep eloquent group, 1.6%, and in the hemispheric group, just under 1%. There's no mortality due to radiation-induced side effects. So we then revisited the group of cavernomas in Sheffield and included patients going up to 2014. So a very significant larger group than in the first cohort. We could basically replicate these results in the deep eloquent lesions. Again, with the treatment protocols to the prescription dose of 12 gray within the brainstem, and within the thalamus and basal ganglia, we use 13 gray. The annual bleed risk you can see here. Again, the very massive reduction of the recurrent hemorrhage risk after 2 years of stereotactic radiosurgery in both groups, the group which has bled only once, or this group who has had multiple hemorrhages in the past. So in both groups, very effective hemorrhage reduction. Here, just a table outlining the figures again after one bleed. Pre-radiosurgery, 2.4% risk of bleeding again within 2 years of stereotactic radiosurgery, 4.3, and then it goes down to 1.1% in the aftermath. So less than half the original risk. Multiple bleeds, 20.7% rebleed rate in the multiple bleed group, and that goes down after 2 years after radiosurgery to 1.3. So a very material reduction of hemorrhage risk. But again, not down to zero. So conclusion, the revalidation of and assessment of our cohort shows that radiosurgery is safe for cavernoma, deep or superficial. 6.7% mild morbidity. Radiosurgery significantly reduces recurrent hemorrhage risk and stabilizes lesions. There appears to be a favorable outcome when compared with the natural history of these abnormalities. Permanent morbidity is caused by rehemorrhage, not by radiosurgical management. And the side effects and the comorbidities caused by radiosurgery are a combination of recurrent hemorrhage despite radiosurgery and radiation-induced side effects, and amounts to about just over 13%. Just a couple of examples. The left thalamic cavernous venous malformations, not an attractive surgical target. The dose plan excluding the hematoma to minimize the volume and to make that treatment as harmless as possible. A perfect cavernoma for radiosurgery in the mid of the brainstem. And another example, like Patrick showed already at the beginning, where surgery clearly is the primary treatment option. Then we looked for good measure at all the hemispheric lesions as well. So they're very different from the location, from the accessibility point of view, and for the attractiveness for microsurgical resection to the deep-seated ones. The outcomes for time purposes, I summarize very quickly, are even a bit more favorable than the deep ones, which is not surprising because the complication rates are a bit lower. Because they are not as eloquently placed. The conclusion we drew is very similar, just with a smaller comorbidity of the radiation effect and the post-radiation hemorrhage risk, which is smaller, interestingly, in the hemispheric lesions than in the deep-seated ones. And that's very similar to what we can see in our arteriovenous malformations. The deep-seated ones have a higher hemorrhage risk. And after all this, we concluded a proposed treatment algorithm where we considered observation, surgical and radiosurgical management in certain clinical scenarios. Now, because we do not resect this lesion and we do not bring down that recurrent hemorrhage risk to zero, so i.e. we do not necessarily achieve in all patients a cure, and we can't prove that we achieved a cure in the ones we did because the imaging modalities don't exist. There has been always that controversy is, are we actually doing the right thing by irradiating cavernomas? Are we better than microsurgical resection because microsurgical resection brings forward the morbidity to the immediate onset during the surgical removal or as a side effect of complications associated with the craniotomy? Or should one just sit on those cavernomas and observe them? And for that, we always discussed that an international trial would be really very helpful to inform us in the decision-making process, to advise patients, to advise colleagues, what's the best treatment modality in what scenario with what comorbidities associated to it. And there was an attempt then to bring on the ground a trial called the CARE trial. And I don't go further into this because Rustam has been the national driver on this for many, many years, predating the actual onset of that trial. And I'm sure you will talk us through all this. And the trial has been concluded and is in the published literature. And we are all very intrigued to hear what Rustam has to say. Thank you very much for listening. And thank you to the team. Without that work, wouldn't have been possible.
Fantastic. Thank you, Matt. That was an excellent overview. And I think you've also introduced our next speaker really for me. So we have Professor Rustam Al-Shahi, who has put a huge amount of work into the management and the running of the CARE trial, and excitingly we've recently published the results. So he's going to take us through an overview of those results and what they mean for Cavernoma management.
Thank you very much, Patrick, and thank you, Matt, for your build up to this. And hello to everybody this evening. I hope you're all still there. So I'm going to present the results of the CARE pilot study to you. My disclosures for this presentation are that I'm paid by the University of Edinburgh and my NHS Health Board, as well as the network of clinical trials units in the UK. And I have done consultancies for Recursion Pharmaceuticals that have an interest in drug treatments for cavernous malformations, but otherwise I have no relevant competing interests. So the CARE pilot phase trial was run by myself and Neil Kitchen, who's on the call tonight, as co-chief investigators, and it really wouldn't have been possible without a multidisciplinary trial management group representing not only all the disciplines involved in the management of people with cavernous malformations, but also the expertise you need to run what really is a very simple experiment, a randomized control trial, but needs to be done extremely carefully for the results to be more robust than any other research design when it comes to treatment, the effects of treatment, and also for the results to be done to high regulatory standards. But most importantly, the two other groups we involved in this trial, which often doesn't happen in randomized control trials, is really meaningful and deep patient and public involvement, and also involvement of qualitative researchers in the study. So I want to thank all these members of the trial management group representing those various different specialties, and many thanks to the patient and carer advisory group chaired by David White, who I think has joined the call this evening, involving many representatives of Cavernoma Ireland, Cavernoma Alliance UK, and people with lived experience of cavernoma. I also want to say thank you to the trial steering committee, an illustrious group of people who've done much larger randomized control trials than this in the past, but we really benefit from their experience. And finally, the data monitoring committee, who reviewed the results of the study as it went along, but without us knowing what the results were. So we remained blinded to the overall results. But this eminent group of people carefully scrutinized the results as we went along to ensure patient safety. But as Matt alluded to, it's taken a very long time to get to the point of doing this randomized control trial. And, you know, I dare say many people on this call have been involved in the management of these conditions and research into them for much longer than I have. But my own personal story started in 1998 when I moved from Queen Square in London, where Patrick and Neil worked, for the far superior natural environment of Scotland and a hotbed of stroke research, to set up a population-based epidemiological study to see what the long-term outcome was for people with cavernous malformations and other vascular abnormalities in the brain, going on to describe how commonly they came to medical attention, how they presented, what the prognosis was, eventually resulting in UK guidelines, which did not identify any high-quality evidence. And I think it's really important to pause here and say, we know in medicine that randomized control trials are the highest standard of evidence, and so much of what we do for common conditions like heart attack or stroke is influenced by those trials that give those patients a really well-informed approach to their management. However, cavernous malformations are a rare disease, But I still think that people with cavernous malformations deserve the highest standard of evidence. It's just much harder to generate it because the disease is rare. So that's why in 2012 we had our first discussion about the need for this study with the SBNS, and comparative studies of people who had radiosurgery and people who didn't came along. And then a randomized control trial, Aruba, was done for arteriovenous malformations, which showed harm from treatment of AVMs that had never bled. Very controversial trial. And then, most significantly for cavernous malformations, we moved on to a James Lind Alliance priority setting partnership with a group of happy people you see bottom left on this slide, where there was a prioritization of the uncertainties for people with cavernous malformations of the brain. And that led in the UK to our national health research funder commissioning a pilot phase trial. And they didn't commission a full international trial, which is what's needed to properly answer this question, because they knew that it couldn't be done in the UK alone, and they are a UK funder. So they thought they'd better see whether we could actually do the trial in miniature. So they issued a call, we applied for it, and a large group of us who you already saw got an award, and then we got on with it and did the study over 3 years, and the results were first presented earlier this year. So that priority setting partnership was a pivotal moment for brain cavernoma, because the top 10 uncertainties ranked in descending order here for this disease included as number 1, should I have treatment with neurosurgery or focused radiation treatment, or no treatment for the cavernous malformation to improve my outcome? So because this was the number 1 uncertainty, that's why the funding agency had to look at this and commission research. And so why was it the number 1 uncertainty? Well, that's because most of the data that Matt has shown you is simply reporting the outcome of people who happen to be treated with stereotactic radiosurgery, often no comparison group, and certainly no randomized design, which is the fairest test of a treatment, because it creates 2 groups of people who are identical, other than the fact that one group gets treatment and the other doesn't. And you know what a difference that made, for example, to understanding COVID vaccination or treatment of COVID recently. So these are the data that we summarized in a systematic review published in 2019, and there are myriad systematic reviews of stereotactic radiosurgery now for brain cavernoma, but 30 cohorts, more than 1,500 people, most of these cavernomas inaccessible by surgery or unsafe for access by surgery, and showing that death was a rare outcome after this treatment, that brain hemorrhage still happened at a risk of more than 2% per year, and that other stroke-like problems relating to cavernomas but not due to bleeding also occurred with the risk of roughly 1% per year. So it wasn't as if bad outcomes from cavernomas completely went away after stereotactic radiosurgery when you look at only people who have them, as Matt was saying earlier. The question is this better than treatment without stereotactic radiosurgery or not? This is another systematic review published at the same time, but taking a different approach from us. These people compared how often patients bled from their cavernoma before they were referred for stereotactic radiosurgery in comparison to how often they bled afterwards. And the vertical line you see there is the line of no effect. And if the risk of bleeding was lower after stereotactic radiosurgery than beforehand, the estimate from the study is to the left-hand side of that line. And you can see most of those estimates are, and overall the summary effect in the red diamond is definitely to the left-hand side. So these are before and after comparisons. That's just for brainstem cavernoma. And this is comparing radiosurgery or neurosurgery in the same before and after fashion, showing that you get the same phenomenon after surgery as you do after radiosurgery. So bleeding risks go down. However, as Matt said, the difference with surgery is the cavernoma is most of the time successfully removed, whereas in radiosurgery, the radiation attempts to obliterate the vasculature and the abnormal vasculature still remains there. But the main problem here is, and I'm sorry this slide isn't projecting properly, but if you look at the red diamonds here, this is showing you for 4 different groups of people with cavernoma, the red diamond representing the sort of people who are generally referred for stereotactic radiosurgery. In other words, those who've had at least one bleed in a cavernoma in the brainstem, that the annual risk of bleeding drops from about 14% in the first year after your first bleed. So this is the risk of a second bleed. 14% in the first year drops to about 8% in the second year, 4% in the third year, and then it remains. So we know that bleeds cluster. The risk of rebleeding is higher early on than it is later. So it's quite possible that those people referred for radiosurgery before they get to the treatment are people who've bled at least once, maybe twice. They're in this high-risk rebleeding group early on. And then you give them the treatment, and it might just be the disease settling down as it does without treatment, as you see here, that's responsible for the good outcome after radiosurgery. We just don't know. So that's why we went on to see if the CARE pilot trial would be possible. And these were our objectives: to form a collaboration, to do a pilot trial of about 60 participants with qualitative research embedded in it, and then to really see whether a main trial would be doable. These are the inclusion and exclusion criteria, and they're very simple. I won't repeat them, but we did not discriminate according to age or sex or ethnicity. Anybody could be included if they had at least one brain cavernoma that was still there and hadn't been removed by surgery, and they previously either had a bleed or an epileptic seizure attributed to that cavernoma. So the collaboration worked, and I'm so pleased about that. And huge thanks to my co-lead Neil Kitchen and the many neurosurgeons at sites around the UK who took part. We had intended to activate 40 sites, but as you can see, we did all of this shortly after the worst of the COVID pandemic, when the research infrastructure in hospitals around the place was really depleted. So we got to nearly 20, we got to 28 neurosurgical sites around the UK, which is really impressive. I think it was bigger than any of the other ongoing neurosurgical trials at the time, which almost met our feasibility metric of 30 sites, represented by that dashed line. In fact, 2 sites in the Republic of Ireland did receive Research Ethics Committee approval to proceed, but there wasn't time by the end of this to go through the other steps to activate them. So we did get ethics approval for 30 sites, which is huge. This is what happened to the various patients who were screened. So we'd anticipated about 300 or so patients will be screened, and 511 were, so we exceeded that. About 2/3 of those people who were screened were eligible, and about 2/3 of the patients who were eligible were actually approached. Some weren't approached about the study because, for example, the doctor was already certain about what to do, or the patient was, or both of them were. So then of roughly 200 people approached, roughly 100 of them, so half of them, were uncertain about whether to have treatment with surgery or not, and so was their doctor. So for the other half of those people, one of those 2 people was certain. Various people weren't randomized, and ultimately we recruited 72 people, which is great because that exceeded our original projection of recruiting 60 people. And you can see in the green line here that we were always trying to catch up with our target in the grey dashed line as we slowly activated fewer sites than we'd hoped for. But in the end, we succeeded, and we actually exceeded our recruitment target with a small extension in time to do that. These are the hospitals that recruited, and those in green fulfilled their promises to recruit at least 3 patients. Those sites in yellow did recruit at least 1 patient, but didn't manage 3. And some sites never recruited any patients at all. And this is often what you see in trials. That's quite a skewed distribution. Sites with some places really having got the knack of the trial and succeeding in successfully explaining the trial and the reasons to be recruited to it to their patients and recruiting well, and other sites, despite their high volume, really not managing it at all, either because the doctors are certain, the patients are certain, or they haven't got the got into the swing really of how to embed a trial like this in routine practice. And we really need to reach that level. You look at oncology. Everybody in oncology, whether it's the doctors or the patients, go in and they want the best standard of care that exists. And then they ask, and which trial am I going into? And that's the only way we can make progress with this disease. So this difference between sites in the UK is just an indication of how adept some people are at recruiting and others aren't. And the only solution is for everybody to behave like we're treating people with cancer, and then we'll make progress. The qualitative study did quite a lot of work to listen into recruitment discussions, did interviews with doctors and others, and basically they found that people's clinical practice, doctors' clinical practice, and what the habit they got into, for example, only referring people for surgery or radiosurgery after they'd had 2 bleeds, got in the way of randomization. People weren't willing to roll that back, even though it's not based on great evidence. It's just the habit we've got into in our clinical routine. Secondly, doctors, when they have uncertainty about conditions or they're managing complex conditions, they usually work in multidisciplinary teams when several specialties are required. And those multidisciplinary teams really aim for groupthink to reach a consensus to form a plan for a patient, which of course is great. We'd all want that. But what happens when there's uncertainty? Well, often groupthink tries to overcome that rather than saying, actually, we're all uncertain. Let's solve this problem. A randomized trial is the answer. So groupthink was another barrier to the trial. And there were logistical issues, not least referring patients for stereotactic radiosurgery, for example, from Scotland, where we needed to apply for funding to do so. But if doctors were willing to offer surgery to patients who they wouldn't, in their usual practice, always offer surgery, but surgery was nonetheless doable and could be beneficial, then that improved recruitment. If we recognized the way multidisciplinary teams think, and manage to have a consensus view and embrace uncertainty, and the CARE study as a solution, that promoted recruitment. And also if we presented taking part in the study to patients as a solution to our collective uncertainty about what to do, that often led to recruitment. I'm not going to labour too much of the data because I know we're hard pressed for time this evening, but the main thing to say is that these 72 patients were divided into 2 groups of 36 each, and that people were randomized one at a time to treatment with medical management and surgery, or treatment without surgery on the right hand side. And broadly, the average age of the adults was about 51 years old, and there were only 4 children randomized, and their average age was around 7 or 10. We had a slight excess of women randomized in the study, and there was a large proportion of people of white ethnicity in the study, not necessarily representative of, for example, England's ethnic diversity in the study. And about 1/5 of people had had a bleed in the past, and sorry, 1/5 of people had not had a bleed in the past, and you see the presentation and characteristics there on the slide. This is just a quick explanation to say on the left-hand side of this slide, this trial tried to be clever by saying, look, if we're going to randomize people to either surgery or no surgery, we recognize that people who are referred for surgery are usually different from those referred for stereotactic radiosurgery. If you go to operate on a cavernoma, you'd rather choose one superficially over the surface of the brain, much less hazardous for a neurosurgeon to access. Whereas if you've got one deep within the brainstem, like the ones you saw earlier on the slides, radiosurgery might be seen as safer and surgery quite perilous. So what we did was, before randomizing people, we said, which treatment would you use if your patient was allocated to surgery? So we divided people effectively into 2 separate comparisons of medical management versus surgery and medical management versus stereotactic radiosurgery. In the interest of time, again, you can see how those patients flowed. But the key thing is that of the 36 people assigned to medical management and surgery, 12 of them had neurosurgical resection and 24 had stereotactic radiosurgery. In other words, there was a 2-to-1 preference in this trial for using stereotactic radiosurgery over surgery. And if you look at the characteristics of people who were allocated to either stereotactic radiosurgery or not, most of them had had a bleed in the past. Fewer than in the surgical group had had epileptic seizures. Fewer than in the surgical group had a lobar, superficial cavernoma, and a much larger number had a symptomatic cavernoma deep below the surface of the brain. So the sorts of characteristics you'd expect. And then if you look at the results during going ahead with treatment, Most of the people assigned to stereotactic radiosurgery did have it, but 3 did not. And this does happen in open trials. And if you are interested in the characteristics of stereotactic radiosurgery, Matt and Neil devised a pretty clear protocol about how these patients should be treated. You can see where they were treated and how. And I think this conforms to what seems to be best practice for cavernomas nowadays. In terms of clinical outcomes, the key headline is in the top row here, that in the 67 people who were followed up at 3 months, 2 had an outcome in the group with surgery and 2 had an outcome in the group with medical management alone. In other words, no difference between the 2 groups. You see on this Kaplan-Meier curve, time going along the x-axis and risk of the primary outcome going up the y-axis, that these curves completely overlap. There's no difference in these treatment strategies over time. But remember, this is in a very small number of patients, and we never thought we would show a definitive difference between these arms because we weren't expecting a dramatic difference. But the important thing is, if you look at the stereotactic radiosurgery group, the 23 people who had that compared to the 22 people in that same group who were randomized to medical management alone, those assigned to stereotactic radiosurgery did not have a primary outcome, whereas those who were assigned to medical management, 2 of them had a primary outcome. So the 2 primary outcomes that occurred in the surgery arm happened after neurosurgery, not stereotactic radiosurgery. So in summary, I think we showed that a trial was possible, that a qualitative sub-study was useful and informative, that overall in the clinical community for this uncertainty, there was a 2-to-1 preference for radiosurgery over neurosurgery, and that quite a large proportion of the people who were eligible and who were approached did indeed take part, and we're really grateful to those people. We didn't identify any safety concerns about radiosurgery in these small numbers, but we don't know what the effects are outside the UK, and that's why a definitive trial is going to need to involve a large number of sites and a large number of participants, which will require not just Batman and Robin, me and Neil. It'll require Avengers all over the world to unite and conduct that trial. And as Matt said earlier, the findings of both the CARE pilot trial and the sub-study are published, and also on the Cavernoma Alliance UK website, we have a short video explaining the findings in plain English. So the final word really should go to the patients who participated in this study. Enormous thanks to them, and huge thanks to Cavernoma Alliance UK, who also supported this study and were really the ones that made it possible.
Thank you, Rustam. So that was fantastic, and we already have questions in the chat about the CARE trial, so we can go through more of a full discussion during the Q&A. If there are any questions, please do put them in the chat, and we will go through them. Our next speaker is Ben Brady, who's in that last picture, and also is works with the Cavernoma Alliance, and he's going to give us the patient's perspective on cavernomas and their management.
Hello, everyone. Thank you to everyone for putting their hearts and expertise into trying to find a solution. Cavernoma, my name's Ben. I live in Scotland now, which is where I met Rustam. 25 years ago, I was diagnosed with cavernoma because I had facial palsy. And I was immediately recommended surgery, so I had surgery, and there was no scan after surgery, and in between that I moved to Scotland, but unfortunately I had another bleed, and so I was scanned again, and it appeared that the cavernoma had returned, and so in Scotland I had surgery again. But this time, being aware that it came back so quickly, last time I had another scan quite quickly, and it had returned again. So I was then recommended ultimately Gamma Knife. So I had Gamma Knife surgery in 2010. And as has been said, it's difficult to tell about the outcomes of Gamma Knife on cavernomas. So unfortunately, I had a bleed after a fairly substantial bleed, and it was around that time that I found Cavernoma Alliance UK. So that was an extremely supportive community. And I began to get involved as a buddy, a volunteer, hosting community chats and hosting community meetups as well for those with Cavernoma in Scotland. So here I am living with the symptoms really of everything that I've gone through. So my main symptoms, I guess, now are pain from my initial operation, just the way it affected the back of my head. So I take daily medication for pain. If I don't take that, then I'm pretty well out of action. So I need that daily. Another massive impact is balance issues. I can no longer really walk well without a stick. I can't walk in the street for more than 50 yards. I bought myself a trike, and an adult trike, so I'm able to get around, which is great. Because of the facial palsy, I've been having plastic surgery as well. So I've had a lot of extensive surgery and muscles removed from parts of my body and put into my face. I've also, I was going to tell you something, I've forgotten what it was, but okay, so basically I've had no seizure for 10 years, and hopefully that's it for me. But I'm still living with all these symptoms. One of the really poor symptoms is the whole left side of my face was knocked out by my brainstem, Cavernoma. So my eye needs a lot of treatment now to keep it lubricated and keep it alive. I've had a lot of plastic surgery in the eye. I now have a gold bar to help my eyelid close and open. And then every hour I need to inject some drops into my eye to keep it lubricated. So yeah, that's my experience. Not wholly positive, but very, very real, and what I have to live with since my diagnosis. I was married at the time, and since then we've had two great children who grew up and left home. So life didn't end when I was diagnosed with Cavernoma, but I do have fairly severe symptoms that I have to deal with now. So thank you very much for listening to me. Thank you, Patrick.
Thank you, Ben. So, that's a real, an excellent description of, what life is like with a cavernoma, and the importance of trials like the trial to make sure we're treating them as best we can, preventing bleeds, and preventing some of the things that happened to you, really. So I think we've got quite a few questions now in the chat, and if everyone can come on the stage, the questions will flash up, and then we can maybe address them one by one. If we just go to the first question, this is from Jana, who is a patient, and her question is, I think we'll break it down into parts. So for patients, it feels important to better understand why some cavernomas bleed and rebleed, others don't. Can we do more research on that? Neil, you've joined us. What's your comments there?
Well, I think there is some work on that to do with MR imaging, using novel sequences to see if there's a handle one can get on this, but it hasn't really been that fruitful, to be honest. You're kind of left with knowing that a minority of cavernomas are going to bleed repetitively, but I still find it quite difficult to know which ones are going to be troublesome and which aren't. And you're left kind of almost like a fait accompli. By the time they've had 2 or 3 bleeds, it's going to be trouble, but it's a bit late then. So I think Matt's point in his presentation about why don't we just treat cavernomas early whilst they've had just 1 bleed will be a stronger point if we knew which ones were definitely going to rebleed or not. So the answer to your question is it's an imaging, it should be an imaging based solution, but which we haven't come to yet. Maybe our AI, dare I say, might, with larger numbers, might be helpful.
Yeah, I was just going to mention that. I mean, I think with the field of radiomics and AI and enough data, that perhaps if you give an algorithm enough scans to look at it, it can start to tease apart why some cavernomas are more active and others aren't. But yes, that is definitely a field for more research. And the second part of that question is, are there differences between people who have incidental cavernomas versus symptoms or those that bleed? Could we, for example, look at the differences between asymptomatic and symptomatic cavernomas in familial cavernoma syndromes? We haven't really talked about genetic cavernoma syndromes. Matt, can you sort of give your opinion on that one?
Well, I think that's very difficult because the only reason why you identify these lesions is because you're looking for them in many patients. The ones you incidentally find, I would not lose sleep over and certainly wouldn't treat them at that stage. I don't think, until you have an imaging modality which can show you why one lesion is more risky than the other, I think we are all walking in the dark. And we just need to go by the clinical presentation and the clinical history. I can't see at the moment any imaging modality coming up apart from what Neil said, some new sequences which might show that there is some enhanced perfusion of that cavernoma, like, for example, an increased contrast uptake over a shorter period of time than in others when you compare that. But that's all speculation. Nothing has been shown on that.
Okay, so it's work in progress, really. We move on to the next question. This is from Yasmina, and it's a question about the CARE trial. So, Ruston, maybe just to summarise, the broad question is, what are the key findings of the CARE trial regarding the effectiveness of surgical versus conservative management of cavernomas? How do these findings impact current clinical practice and decision-making for treating patients with cavernomas? So what's the impact on our clinical practice?
Yeah, thanks, Yasmina, for the question. So the first thing to clarify is that the CARE pilot trial did not directly compare surgery and radiosurgery. It was a comparison of treatment with surgery versus treatment without, and the randomization was stratified. You'll remember that in the two groups of roughly 33 people, there were 2 people with a primary outcome in the medical management group and 2 in the surgery group. And those 2 adverse outcomes in the surgery group happened after neurosurgery, not after stereotactic radiosurgery. But the numbers of outcomes here are very small, and we know there may be an upfront risk after neurosurgical excision, and the trade-off might be the long-term gain of complete removal of a cavernoma. So I think that's all we can say really about what happened in surgery. The numbers of people in the study were too small really to definitively change clinical practice, but I think they're reassuring in that what they show is no difference between the 2 management approaches that we use in standard practice, medical management alone or medical management with surgery. And they also reassuringly do not show a dramatic increase in risk after either of those in comparison to what we already know about what happens in everyday practice. So I think the findings at the moment are permissive of what we do in clinical practice, but the key thing is they still beg the question, what's the best approach? And answer that. And the only way to answer that is to put a 0 on the end of the number of people who were recruited, and then we'll know for sure.
Okay, and so the next question is, do you have experience in radiosurgery after partially resected brainstem cavernomas? So for Matt and Neil, really.
Well, I think I don't think we have a very. I don't have a large personal experience of that, if done any at all. I think there are two different cohorts of patients you have to think about. You can't directly compare surgery for brainstem cavernomas with radiosurgery for brainstem cavernomas anyway, because the size difference tends to be enormous, so they're not really directly comparable groups. On the other hand, yes, it's quite obvious that on many occasions small pieces of cavernomas are left behind because of accessibility problems or bleeding during surgery. Matt will have a bigger experience, I'm sure, from being referred patients over the years, so I defer to him on this.
I mean, from the targeting point of view, it is very simple. It is not as unattractive as it is for a revisional surgical approach, because you don't need to be concerned about the scarring, the artifacts during surgical intervention from a previous hemorrhage and hemosiderin staining, etc. So radiosurgery for a remnant cavernoma is rather straightforward. It's not an issue. It's not a problem. The same problem applies. We can't tell you if you have been successful. There's no imaging study which tells you that, or which allows me to tell you that I have cured you. So there remains that little bit of uncertainty, and which only future will tell.
But I think you would say that if you did have a partially resected cavernoma, which was not demonstrating any evidence of activity or bleeding, probably you would wait to see if it was active again, and then you would consider treatment rather than go straight to radiosurgery.
Well, no, I wouldn't, because if it was bad enough to go in for microsurgical resection, then that's an indicator that is probably one of the more aggressive lesions you want to treat. So if you have not completed that management with your microsurgical approach, I would irradiate the remnant.
Yeah, I agree with Matt. I think you can't guarantee that the bit that's left behind is a benign bit of it. I think you have to treat the whole thing.
Yeah.
Okay, excellent. So next question is then from Daniel Lumley. And this question is about genetic testing. So with the prevalence of patients presenting symptomatically, would genetic testing for hereditary cavernomas be a worthwhile addition to the management pathway? So when do we do genetic testing?
Well, I think genetic testing is good for a pathology which you can cure, and or you know that you prospectively look out for issues. You give advice about having children yourself, etc., etc. So where a positive pathway can be chosen. I'm not sure that would be too helpful with Cavernomas, because if you have 20 of them in your brain, we wouldn't treat them all. We wouldn't prospectively treat them. It would impact quite significant, probably psychologically, on your outlook on life and how you cope with that knowledge, etc. So I would be very careful about prospective diagnostic in hereditary issues. That needs to be left to the individual and to the family of that individual, and what they really want and how they would want to go about it.
I agree, Matt. I think that the blood test is simple, but the sequelae can be quite complicated and long-reaching. So I tend to defer patients to a separate genetics clinic if that's what they want to think about.
Okay. Got another question from Yasmina. Based on the outcomes of the CARE trial, what future research directions do you recommend? And are there specific patient populations or cavernoma characteristics that warrant further investigation? I want to bring Ben into this just from the patient perspective from the Cavernoma Alliance on future research directions, and then maybe Ruston as well.
Okay, could you highlight a question for me? Just so I can clear.
just really about future research directions based on the outcome of the CARE trials. So from the patient organisation perspective, you know, is there a big impetus towards the main phase trial, other trials?
Yeah, I mean, I guess just we want to head for certainty, really. Certainty in the end, of course, but on the way, there's so much that we don't know. So anything that heads towards certainty, like genetics, I'm not sure what AI will do. But yeah, that's what I would say, because one of the main issues with having cavernoma is the not knowing, and that really creates a lot of anxiety and fear within the cavernoma community. So anything that heads towards certainty would help.
Okay, and Rustam, your thoughts on that?
I mean, the big question, of course, is can we do a definitive large trial to properly answer this question? That's the huge issue now, isn't it? After showing we can do the pilot phase study, and I think, to be honest with you, if we've got an audience of people who are mostly interested in stereotactic radiosurgery, it seems to me that with a 2-to-1 ratio between radiosurgery and neurosurgery preferred in the CARE pilot trial, and the fact that if people do have radiosurgery for cavernomas around the world, it's usually in individual centres of expertise which manage large volumes of patients. That's an extremely efficient way to deliver a large study at a small number of places, where there are well-defined protocols and established expertise in delivering the intervention in question. So what I'd love this audience to conclude, and this meeting to conclude, is that yes, we can do a big definitive trial through international stereotactic radiosurgery centres.
And your feeling is moving towards focusing specifically on radiosurgery and excluding the surgery arm, is that?
I mean, I'm just going on the basis of what the numbers told me in that study and how hard it is to get neurosurgeons to randomise patients, Patrick.
Matt and Neil, you both agree?
Yeah, I mean, it has shown that it is difficult, and there are just very entrenched opinions out there in different centers, and you know, they're not based on class 1 evidence, which is what we are all trying to achieve, to get. So I think it is important that we answer that question for all parties involved.
And Neil, you're nodding as well.
Well, I think we haven't. I'm leaning that way, but you know, we just need to discuss within the neurosurgical community and others to find a way forward. What is practicable?
Yeah. Okay, we have a question from Lancet, which is always an interesting question. Do radiation-induced cavernomas have an impact in decision-making for treatment? So your cavernoma is caused by radiation. What treatment would you have? Can you have radiosurgery, for example?
Yeah, you can have radiosurgery. The problem with radiation-induced cavernomas is that they are often multiple. So, and we would only treat them once they have become symptomatic and hemorrhaged. So it's basically the observation and waiting for that symptomatic event.
Yeah, okay. Neil's just dropped off, I think. So, and then maybe should we make this the last question? We're just coming to the end of the webinar. This is from Natalie Ryan, and again, it's really in 2 parts, I think. So, Rustam, are you planning to run a natural history study alongside the next stage of the trial so that those who opt for surveillance alone can contribute to research?
Yeah, I mean, we know a lot about natural history, but with the interest in whether there are other prognostic factors that we haven't yet identified, that would be a worthwhile exercise, and it would also give people who don't take part in the trial something to contribute to. However, when I tried to do that with the CARE pilot study, the funding agency declined to fund that part of the trial because they know from their experience with that sort of design that if investigators know they can recruit a patient but they don't have to put them in the randomized trial, and they can put them in something else, it disincentivizes randomization. So it works against the purpose of the study. So I would like to do it, but whether anybody would fund it or not, I don't know.
Okay, and there's a question about, does the risk of bleeding change with time? So if you've had a cavernoma for 10 years after a single symptomatic bleed, is the risk of further bleeds changed? And also a question about how you define a bleed. So is it symptomatic events only, or is it radiological bleeding?
In a nutshell, Patrick, I'm defining bleeding as symptomatic bleeding, and there's an Angioma Alliance, as the USA patient organization used to be called. We developed a consensus definition of what hemorrhage from a cavernoma is, because quite often people have just said it's new bleed on the scan, but it needs to be symptomatic because that's what matters to patients. Second, in answer to the first bit, I showed you the data on how early rebleeding risk does decline over time, but nobody's really done extremely long-term follow-up of people with cavernomas. We've now got more than 25 years of follow-up with our cohort in Scotland, and there's a Dutch student coming over in a month or two to look at our very long-term data. But my sense of my clinical practice is that there's a flurry of events from cavernomas soon after presentation, and I don't see people who've been medically managed coming back to me 10, 15, 20 years later with rebleeds. Things do seem, in my clinical experience, things do seem to go very quiet in the long term, but it would be nice to have data to show that.
Yeah, I think we absolutely agree, Rustin, and it's quite an interesting area of study. We're doing similar work around aneurysms, doing conditional probability modelling for aneurysms that have been followed up for 10 or 15 years. So what can you say your yearly risk of the bleed is at that stage? So that's also an area for research. So, okay, let's just do the last question then. This is from Payman. Any difference in terms of rebleeding rates between low dose SRS versus high dose SRS? Matt, anything about dosing there?
Well, we don't really give a high dose. So we are tailoring the dose between 12 and 15 Gray. So that's not what I consider a high dose. A high dose would be 25 Gray. So we don't treat that cavernoma with those kind of doses. So,
and how are you deciding between sort of 12 to 15?
Oh, that's down to volume and location. That's left to the individual on the day.
Okay. Okay, excellent. So I think that concludes today. Thanks again for all the speakers for their fantastic talks and answering the questions. Thank you, Rustin. Thank you, Ben. Thank you, Matt. And hopefully you'll be joining us soon for another webinar in the coming months.
Thank you. Bye.
Thank you. Bye.